Well, thank you very much, Anne. What a generous introduction. I'm going to talk about the revising of a national strategy, and of course I'm going to talk about what's been happening in the last year or so in England, but all the countries of the UK and quite a few other countries outside are going through a similar process where key questions are being addressed, consultations are taking place, evidence is being reviewed, and so I hope that what I have to tell you is helpful. I must say I'm not presenting the English experience as being perfect, because it hasn't been perfect. And there are still quite a few unresolved issues, not least whether we should have a target, what that target should be, who should take primary responsibility for delivering suicide prevention in localities, and what does accountability mean in a modern era. So quite a lot of things that are unclear, but what I can talk about in more detail is how we've addressed the issue of what should be in a national strategy. So that's where my main focus is going to be. We first had a strategy in 2002 in England, and then 10 years later we reviewed it and kept the main structure but changed certain things, and the biggest change in 2012 was that we added a section on supporting people who were bereaved by suicide. So that was a really major addition to what had gone before. And now it's now 11 years further on, we want to make it as up-to-date and forward-looking as that change was in 2012. So I'm going to talk about how you decide who might be in a suicide prevention strategy. I'm going to call on data from the Office for National Statistics. Quite a lot of the data from them is about England. Quite often it's about England and Wales, so you will see that will change at times during my talk. But also data from the National Confidential Inquiry, which is in my research unit, quite a big project focusing primarily on people under mental health care. But for the purpose of today, I'm going to mention one or two of our other studies. And there, the figures that we present are often from the UK as a whole. It doesn't really matter, the same issues arise. And as we always say when we show data, these are not dry figures, these are real lives. So the figures you will see, the graphs, the numbers, the percentages, these are real lives, preventable deaths, not prevented. We also say that no rate is acceptable. So you will hear me talking about rates that are high or low, going up or down, but no rate of suicide is acceptable. Let's move on. So this is England and Wales. This is ONS data on the national suicide rate over the last 40 years or so, the most recent 40 years up until the most recent complete figure of 2021. ONS figures are based on registration of death, so that's the time when post-inquest a death is recorded. These are the most recent figures. And as you can see, there's a degree of change during this time, but perhaps the most interesting thing about these figures is that they are historically quite low. So the figures since 2020 have been about 20% lower on average than the figures in the 1990s and 1980s. So this is a relatively low suicide period. But during this period, the rates have not been uniform. I suppose that the important thing about the rates being comparatively low during this time and falling for at least the first part of the graph is a very important one when you're putting together a strategy. Suicide is preventable. All the evidence is suicide is preventable, and the data tell us that. So we've got a graph here showing the rates of the last 40 years. If you look at the middle line, which is a combination of males and females, so men and women combined, you'll see the pattern there. There is a gradual fall during the early part of this period, leading to, let's just see if I can get this to work. I hope you can see that, leading to this point here, 2007. And this point is the lowest suicide rate on record for England, and I think for England or Wales. So it's the lowest suicide rate on record, and records began in 1861. So it is a 150-year low. Prevention is possible. And here is the rate in 2017, and that was almost as low. And so the question is, what happened in between? Why was there this? Why did this happen in between? And the answer is the 2008 recession, which starts here but reaches a peak around about 2013. And at its peak, it may not look very much in the way that slides like this are drawn, but at its peak it corresponded to approximately 700 extra deaths per year. So a very big impact of the recession, and you will understand the implication of that as we head into what's become known as the cost of living crisis. The biggest danger to suicide rates at the moment is the economy. And the most important thing for any strategy to tackle at the moment is the economic adversity that many people will face. And then we get back to 2017, and then we have this rise here. Why did we have another rise in 2017? And the main answer, although probably not the only answer, is that the definition of suicide at inquest changed. So the so-called standard of proof changed from beyond reasonable doubt to balance of probabilities. The threshold was lowered, so of course the numbers went up. And it means that these figures here are not strictly comparable to the figures that went before. They're not very different, but they are sufficiently different for us to have that in mind when we're examining trends. Okay, so you have to start with a strategy by seeing what is your big task addressing the immediate stresses that people will face. But when we think about suicide risk, there are quite a few well-known causes of rising and to some extent falling rates. What in the suicide prevention world often called the big drivers of suicide. So there are many things that influence suicide risk in an individual. People's lives are complex. But at population level, there are certain big drivers that if you're going to change the suicide rate, if you're going to bring the suicide rate down for a whole country, you have to be addressing the big drivers. These are the things that determine the suicide rate. So here in the UK, the economy I've mentioned, isolation, alcohol, mental illness and how we treat it. Those have to be the big targets of any national strategy. What about how we bring suicide rates down? So that's these things here. The so-called protective factors. Even if you can't affect risk, maybe you can bolster the protection around people who might be vulnerable. And most of the protective factors that we know about are about supporting people, about connectedness, about community, about being good neighbors and looking out for each other. And that's what all of these images, in one way or another, are depicting. So protection is partly about stronger communities. It's about that sense of feeling connected. And where that really mattered was when we faced the pandemic, particularly in 2020, when it was unclear what might happen to mental health, but there was a great deal of anxiety that the pandemic experience would put the national suicide rate up. Now, we had a big problem because suicide rates in England and Wales are calculated, as I've mentioned, after inquests, after registration of a death, and the time from when a death occurs to the time when it's registered is on average around 6 months. And that's the average. So many deaths are registered 9 or 12 months, even longer, after the death occurred. So it's not very good as a means of the registration death rate. It's not very good as a way of monitoring what might be a very rapid, what we worried at the time was going to be a very rapid change in the suicide rate. So we needed a different system, and that different system is real-time surveillance, RTS as it's often called, and that's about monitoring suspected suicide deaths pre-inquest at the time when they occurred and recording them. Now, in England, we didn't have national RTS, so we had to call on those parts of the country that had developed relatively mature systems and pool their data so that we got a picture of what was happening across the country. And so this slide is showing the pooled data. It was a number of areas around the country. They added in up altogether to a population of about 13 million people. So it's about a quarter of the population. And here is the pandemic period. So this is pre-pandemic. We had to compare to the months pre-pandemic. And then we went into lockdown. And then you'll remember what happened post-lockdown. Then the second period of lockdown. And throughout, into early and throughout 2021. Now, there is some volatility in that figure. So that middle line, again, males and females combined, the yellow line. There is some volatility there, but there is no difference. There is no significant difference during that time. So against expectation, the suicide rate didn't rise during the first year and a half or so of the pandemic. And that finding was corroborated by most other countries around the world. Why did it not go up? Why, when we were so concerned about mental health, and there's a lot of evidence now that people's mental health was adversely affected, why did that distress not translate into the despair that often precedes suicide? Well, the short answer is we can only speculate, but one possible explanation is that sense of community, that sense of social cohesion, getting through a crisis together, mutual support. And if so, then one thing we need to get into a national strategy is the positives. We learn from the positives and make sure that that strengthening of community support, that looking out for people who are on the margins, who might be more vulnerable, that becomes part of the national task. So it might have been those things. It may also have been some of the economic protections that were put in place. And if so, I've already mentioned the stresses of the economy. If so, then those economic protections have to be in place again. And because of that peak that I mentioned in 2013, they have to be long-term. The changing nature of economic stress in people's lives means that we need a flexible economic support and one that goes over the next few years. Oh, sorry, pressing the wrong thing, that's right. So we learn from the positives, we address the main drivers. What else should you put in a national strategy? Well, of course, everybody wants to put in people who are at highest risk. Of course, that's where a strategy will often start. But many of the groups of concern are not groups at high risk. Or we don't have the data to show that they're at high risk. So who can we say with certainty is at high risk? And this is the age and sex breakdown of the most recent suicide figures for England and Wales, showing the most obvious thing, first of all, which is that the green bars, which is the male suicide rate at different age groups, are consistently higher than the red bars. Those are the female rates. The male rate 3 times as high as the female rate, but that rate is not uniform over time. So it starts relatively low here in young people and then rises to a peak in middle age, people in their 40s and 50s. It's true of men, but to some extent it's true of women as well. But in the case of men, a clear high-risk group. Why is that middle-aged male group? Why about a third of all suicides in England and Wales are men in their 40s and 50s? Why is that? Well, it's probably those big drivers, the economy, alcohol, and mental illness and how we treat it, or in the case of men, how they get access to treatment. It may also include a variety of economic factors, including gambling, putting stress on people and people's lives and people's families. Well, most of us know about the high risk of suicide in middle age. What people are less aware of tends to be this second peak here, which is older men in their 80s and above. And for them, the suicide risks lie elsewhere. They lie in isolation, remember the big drivers, isolation, in physical ill health, and in bereavement. And so the preventive task for older men is different, addressing the things that put that older group at risk. Now, when we talk about the risk in men, particularly that middle-aged male group, what always comes up is the difficulty that men sometimes have in seeking help. And so this is a result of one of the studies that we did in my unit, where we looked at the circumstances of suicide of a group of middle-aged men nationally across the UK, about 200 men, taking information from inquests and other official sources to try and find out, first of all, what stresses they were facing, but in particular, what kind of services they'd looked for help from. And what we found was that the majority of those men had sought some kind of help at some time. So it was simplistic, it is simplistic, to say that men don't seek help. They often do seek help, but not necessarily in a way that elicits the response that they need. More striking still was that about 2/3 of those men had sought help in the 3 months before they died. 1/3 in the week before they died. And where they seek help was quite varied. It could be primary care, but it might be mental health services or A&E departments, or the justice system, very important part of suicide prevention. But it did suggest that there are opportunities, at least, to do better with middle-aged men, to be more receptive when they do seek help. Now, it's not an easy task, I don't want to pretend otherwise. Men will often not walk through a door marked mental health or even health, and so we have to have other ways of bringing them into a conversation about their lives and about the stresses they face. The third sector has been good at this, and many of the projects that I'm aware of that have focused on middle-aged men have been from the third sector. And they often take place in non-clinical settings, in non-statutory settings, places where men can come to talk about sport or about male activities, DIY, the kind of thing that may get a conversation going amongst male groups, which can then turn to some of the emotional issues that are otherwise hidden. These are just some of the projects around the country. I just wanted to acknowledge some of them. They're often local. There's one there from Yorkshire, another one from Somerset. Good, very good local third sector projects. And it's our job, and my clinical work was always in statutory services, but it's our job in statutory services to work with the voluntary sector on supporting this group. So, okay, you can think about people who are at highest risk, but you can also think of those who are at greater risk than other similar people. So this is, I suppose, a way of saying that if you're putting together a national strategy, you have to be aware of the political context that you're working in. And the political context in England at the moment is highlighting the so-called levelling up programme, or as we used to call it, inequalities. So levelling up. So if you can align what you're trying to achieve with another area of central policy, then you've got a better chance. Then it can link into something which the government is committed to doing. So in England, the inequality of suicide rates across the country is pretty stark. So this is at regional level. So you can see there that the highest rates, this is one of those colour-coded maps, and the highest rates, it's pretty obvious really, the highest rates are in the northeast, in the north generally, but in the northeast, and the lowest rates are in London. This is the most recent figures from ONS, 2021 again. There's Wales, some sort of at the high end, I think, because most of these are quite substantially above the lowest regional rate, which is London. The rate in the northeast is more than twice the rate in London. But it's more complex than that, because the geographical variation in suicide rates is not just regional. And increasingly, we are seeing a pattern of higher rates in coastal and rural areas. Often in small towns, not big cities. The demography is changing. The social risk that lies behind suicide has been changing. And the highest rates now in England are in Torbay, in Devon, along the Sussex coast, in some of the rural towns of Lancashire, in places like Middlesbrough, coincidentally my birthplace. Those are the places with the highest suicide rates in England. What have they got in common? Small towns, some of them in the countryside, some of them on the coast. Something has happened to the way that those places live and the people who live there. But when we talk about risk, one group always stands out, and that's people who are under mental health care. Historically, a lot of research showing a very big increase in risk in people who have mental illness, maybe tenfold in some more severe illnesses. And in the National Confidential Inquiry, we study suicide by mental health patients, people in contact with services in the year before they die, looking for the things that are happening in their lives, the characteristics of their risk that could be the target of prevention. So this is a case series. It's not a risk factor study. We know what a lot of the risk factors are. This is looking at how common they are. What's the potential prevention from targeting those risk factors? And so this is just a summary of our most recent report. We've got another one coming out in about 2 months, but the most recent report, 2022 report, covering 10 years of patient deaths across the UK. So England and Wales, but also Scotland and Northern Ireland combined. And the number of patient suicides during that time, 10 years or so, was over 18,000. It's worth pausing sometimes on these numbers. 18,000 deaths of mental health patients, people who are already in contact with mental health services. What do we know about them? Well, we know that those big drivers are common in this group too. We sometimes talk about clinical prevention and the social prevention as if they're different, but there's a huge overlap between the two. Patients who are at risk often face the same social stresses as you find in the non-patient population. So in the patient group, we see high rates of social adversity, many people isolated or living alone, or facing economic stress in the form of being unemployed. That, over the period of time, has been our marker. But they also face clinical risks, clinical comorbidities, self-harm, one of the most important risk indicators. Self-harm, a point of contact with the service where we can intervene. So self-harm service is crucial to prevention. So high rates of self-harm, high rates of alcohol and drug misuse. So those big drivers, again, the targets of prevention in patients. And then there's this. On the slide, I thought I would add something which, to me at least, seems important. That just about 1 in 10 of the patients who die around about a significant date. And given that we're taking this information from clinicians, it's bound to be an underestimation because of things that we just don't know. So 1 in 10 patient deaths happen on a significant date, an anniversary, a birthday, some date that means something personal to that individual. And it's the best example I can think of where we need to go with risk assessment. Now, I'm not going to talk in detail about risk assessment and how it needs to change, how we need to get rid of the risk assessment instruments, because my colleague Nav Kapoor has just been talking about that. But a good example of what needs to come instead, a personalized model of risk management based on the individual's lives, the individual lives, that's where we need to get to. And this sense of the personal anniversary, the personal date, the significant time of the year is crucial. A lot of deaths under mental health care cluster around the time of acute illness. So around about a third happen in inpatient care or just after inpatient care or during crisis team support. So the big target for services has to be that period in the acute care pathway, that small number of weeks, maybe a few months, when people are going to be at greatest risk. And so far, the performance of services in this area has been excellent. So we don't always get that message about suicide prevention in mental health care, but there are some real achievements, and it's a great tribute to staff, how some of the numbers have come down. And this slide is showing that. This is inpatient suicide across the UK over the last 10 or so years. And you can see the numbers have come down. That's the top line. If we went back to when we started collecting data, they're coming down even more. They've come down about 60 or 70% inpatient deaths in the last 20 years. Now, that's the good news. There's always a but in suicide statistics, and the but in this case is that the fall seems to have stalled. And so we need to reinvigorate our attention to the safety of inpatients. And bear in mind that Inpatient suicide and ward suicide are not the same. Only about a third of people who die as inpatients actually die on the ward. And for them, of course, the answer is vigilance and physical safety. But about a half will die on leave that has been agreed. So they're off the ward on agreed leave, agreed with staff. And that's usually towards the end of an admission when people are taking that step across the transition back to the community, back to their homes. And it's at that point that their risk becomes much greater. The protections drop and their risk maintains. So our approach to clinical safety has to start with inpatient care and focus on that period of transition back to the community. And that sense of step down, that return to the community, is also a feature of the highest risk for mental health patients, which is when they first leave the ward, when they're first discharged. It's a very high risk period. Something like 2 or 3 times as many deaths occur in the first 3 months after leaving hospital as occur as inpatients, much higher. But it's not a uniform risk. The risk is greatest in the first 2 weeks. These are the numbers week by week in the post-discharge period. The figures are much higher in the first 2 weeks. And in that first 2 weeks, the people who die are people who are returning to the stresses in their lives that may have brought them in. Stresses with their social support, stresses which could be financial or economic. So the highest risk there in the first week. But in fact, you can be more precise than that with the data we have. The highest risk is actually on the 3rd day when people leave hospital. So patients leave hospital, they hit their risk immediately, and our services have to be flexible enough to pick that up. There's no point in having follow-up that occurs at 7 days because you've missed the time of maximum risk. Follow-up after hospital discharge has to be early, has to be within those first 2 to 3 days. Now, in the confidential inquiry, we put all this data into our analysis. We conduct a series of studies. I'm sorry, it's a terrible insult to my staff that I'm condensing their fantastic work into one slide. But there we look at all the things that might have influenced a person's risk, in particular the nature of care, and we try to understand what might make a difference to patient safety in the future. And we call that the 10 ways to improve safety, because these are the 10, in our data, the 10 best evidenced interventions that can make a difference. And so some of what I've talked about today needs to be in a strategy, safer wards, early follow-up, here again dealing with patients who've got comorbid alcohol use, outreach services, personalized risk management, but also some of crisis teams there, but also learning the lessons. Services need to be learning, institutions learning about safety, learning what went wrong. And we find that when they do that with the support of the families who are bereaved, the learning is much greater. So the marker for learning culture in our data is this, reviewing serious incidents with the help of families. So that's mental health care. People dying in close proximity to care, a crucial area. So where have we got to? We've got the cost of living crisis, we've got the inequalities across the country, we've got learning the lessons of COVID, we've got groups at high risk like men and mental health patients. What about young people? Now, young people would be on anybody's list of important groups for prevention, but young people are not at high risk. Their risk is the lowest of any age group. And so the question arises, what is it about young people that makes us feel that they are our, if not top priority, then one of our top priorities? I think the first thing is and we have to acknowledge this, it's hard to say because it could be misinterpreted, but there is something about the death of a young person which is particularly distressing, particularly challenging to our sense of who we are as a society. So there's one thing. It clashes with who we think we are, with our values. But also, rates in young people have been rising, and they've been rising since about 2010. And so again, look at the blue line, that's males and females, the middle line, males and females combined. And since around 2010, that's the middle of the graph here. All right, there's a little bit of volatility, but a more or less consistent rise over time, so that our rates at the moment for, I should say these are young people, meaning people under 20, so that our rates at the moment for young girls are at the highest level we've seen for about 40 years. And for young, and overall for men and or young men, and for the group as a whole, the highest for about 20 years. Now, they're not so unusual because we've had higher rates, or rates at a similar level at the turn of the century. But this is a major difficulty, it's a major priority for us all. And we have to understand what it is about the lives of young people that have added to their risk over the last decade or so. So we did another of those studies where we, as with the middle-aged men, where we got hold of a lot of reports, inquest data on young people who died to try to understand what was happening in the lives of young people across the UK who died by suicide. This time it was 600 young people under the age of 20. So again, just worth pausing on the figure, 600 people under the age of 20 over a 3-year time period in this study. And it was their tragedies that formed the basis of this study. What did we find? What was going on in those young people's lives? Well, suicide is never one thing, so suicide prevention is never one thing. But if we have to target certain things in prevention, here is what those things might be. Some of the risks that young people face started early. Difficult early family lives, with drug misuse in parents, witness to domestic violence, abuse and neglect, coming out of care, and then getting into the teenage years where they faced bullying, bereavement. About a quarter of the young people had what still seemed to be a significant bereavement. 1 in 10 was a suicide bereavement, the sense of a contagion, a chain reaction, one death leading to another. Academic pressures. Some of the young people actually died on the day of an exam. And then we get into online risk and then some more, you could say, more adult-sounding risk factors, alcohol and drugs and mental illness. So what about online risk? What do we know about that? Well, in this study, we found that about a quarter of the young people had been using the internet in a way which we referred to as suicide-related. So that would often mean social media, but more often than social media, it would mean searching the internet for information about suicide, often for information about suicide methods. So when we talk about online safety, a lot of the online safety discussion has been dominated by the behavior of social media companies, and that's very understandable. That sense of social responsibility that some of them have been dragged towards, it's understandable that that's where the focus has been. But just as big a risk is the Wild West that is the internet and the information that's easily available to young people who might be distressed. So when we introduce better safety, the government's bringing in an online safety bill, as you'll know. When we do that, we have to make sure that it's addressing the breadth of risk that young people might face. It isn't only, important though it is, about social media. Just in passing, I want to mention, I'm not talking in detail today, but LGBT young people, about 5% of our group, that's about 10 people per year, undoubtedly an underestimate. And it's worth saying that those young people have faced more bullying, more intimidation than the group as a whole. That gives you an idea of the kind of risks that young people can face. So, finally then, all of these things can go into a strategy. What about new factors, new evidence, new groups that we should be concerned about? A lot of discussion over the last 10 years or so has gone into trying to understand suicide and ethnicity. And finally, in September the year before last, so just over a year ago, ONS were able to report suicide rates in ethnic minorities. So these are not patients, these are national general population suicide rates. And it's a slightly odd-looking graph, I'm afraid. It's ONS's graph. But it's showing you the suicide rates over time, and each color represents a different ethnicity. The first thing to say, these are males, obviously, these are females. The first thing to say is that there is no single rate. So very important, we have to get away from talking about ethnic minorities as if there's going to be a single suicide rate, a single kind of risk. People's lives are complex, remember that. Suicide is never one thing. Prevention is never one thing. So the different groups that ONS looked at, they had very different groups, very different rates of suicide. But most of those rates were low compared to this line here, which is the majority white population. Sorry, it's this one here, the purple. So most ethnic minority suicide rates were low, not high. But there was one exception, And the exception is the green line here in males and the green line here in females, high rates throughout the period of study. And that group is people of mixed or multiple ethnicity. Now, why should that be? We don't know, but it raises questions about alienation from society, that sense of community that I talked about at the beginning should be designed to reflect a diverse society and the community supports that should go with it. And then there is domestic violence. I made a reference to it a moment ago, but this is now experiencing personal experience of domestic violence. Different kind of study led by a colleague of mine, Sally McManus, based on a national mental health survey called the Adult Psychiatric Morbidity Survey, a survey of people's mental health and what might be contributing to it. So here we are. This survey, here's a publication came out last year. Very interesting because not for the first time, but for perhaps the most convincing time, we saw a very clear relationship between self-harm, known as suicide attempts in the study, and domestic violence, referred to as intimate partner violence in the study. A strong relationship and a two-way relationship. So people with, those people who'd had a recent suicide attempt, about half of them had a history somewhere in their background of domestic violence. And putting it the other way around, in those who'd experienced previous intimate partner violence, they were about 3 times more likely to self-harm or to attempt suicide. So a strong relationship between the two. Very important now to reflect that in national strategies. And what does that mean in practice? It means that issue that I referred to of risk management, of assessing risk, needs to be brought up to date too, more personalized, and that means inquiring to people, and it's men and women, but particularly women, of their experience when they've self-harmed or when they might be at risk. What's their likely experience of domestic violence and intimidation? So in summary, a lot of things go into a national suicide prevention strategy. This is some of the more recent ones that we need to add in. So we've got middle-aged men, we've got mental health patients, but there are new things that now need to be brought into play. I've talked about some of them today: ethnicity, online harms, domestic violence, gambling. Haven't said much about that, but I referenced it. The lessons from the COVID pandemic, LGBT groups, economic stresses, so important, and then in the end, this factor here, data. We only knew what was happening in the pandemic because we had good immediate data. So data is vital. Good data is vital because suicide is a constantly changing phenomenon and we need to be constantly vigilant. Thanks very much for listening.